Hello everyone, welcome to Radiology Case Review Series. In this video, we are going to look at images of a teenager who was referred to the emergency department by optometrist. Optometrist noticed patient had mild papal edema. Upon evaluation of the patient by ophthalmologist in the emergency department, they noticed that patient has right homonymous hemianopsia. Patient was referred for MRI orbits examination. On the MRI orbits, as I scroll, no high signal focus is identified in the optic nerves. As I scroll posteriorly, we see the prechiasmatic optic nerve which has normal signal focus, region of optic chiasm, no obvious signal abnormality. But as I scroll posteriorly, in the region of left optic tract, we can see high signal focus. We can clearly see high signal focus in the left optic tract. Compare that to the normal signal in the right optic tract. So these signal changes would explain patient's right homonymous hemianopsia. Patient was further evaluated by neurologist who upon further interrogation noticed that patient had tingling and numbness sensation in both upper and lower extremities on and off over the past 2 years. So now they were concerned for underlying demyelinating disorder and patient was referred for MRI brain examination. On the sagittal flare images, we can see high signal focus at the callosocaptal interface. We can also see some high signal focus in the body of corpus callosum. As I scroll through the parasagittal region, we can see multiple flare hyperintense foci which are aligned perpendicular to the ventricular wall in the expected direction of the medullary veins. We see similar findings on the axillary formats of the brain. So we can see multiple flare hyperintense foci which are seen in the periventricular, deep and subcortical white matters. Some of these lesions appears to be aligned perpendicular to the ventricular wall along the expected course of medullary veins. Following administration of intravenous contrast, some of these lesions demonstrates peripheral rim enhancement. Some of these lesions have incomplete ring enhancement, and if we look, the incomplete ring appears to be pointing towards the ventricular wall. Imaging appearances are concerning for underlying demyelinating disorder. Patient underwent lumbar puncture for CSF analysis which came back positive for oligoconal bands. In constellation, imaging appearances are concerning for underlying multiple sclerosis. So this is a nice update from radiographics on white matter lesions. So our patient would meet the McDonald 2017 criteria. The criteria was updated. So in terms of diagnosis, we need two conditions: dissemination of lesions in space and time. In terms of lesions, they can be seen in the periventricular, juxtacortical, infracortical or spinal cord. In the 2017 update, they also included cortical lesions for classic locations. So in terms of dissemination in space, there has to be one lesion at two classic locations, and in terms of dissemination in time, on a single MRI, if we have both enhancing and non-enhancing lesions, which is what our patient had, it would meet the criteria. Or if there is a new lesion on the follow-up MRI, it would also meet the criteria for dissemination in time. I hope you found this case to be informative. Thanks for your attention.